Okay, all right. Thanks, everyone. We should get going because it's give a little extra time for some chit chat. Anyway, thanks everyone for coming to this September meeting, Public Health Advisory Board. We're going to save the extensive introductions of the new members, welcome new members, till after announcements and updates, because our presenter today cannot start presenting till about 1. So we changed around the order. Anyway, we can go around the room and introduce folks, starting with Tom.
Yeah, hi, Tom Kuhn. I work at Deschutes County Public Health, and I'm the coordinator of PHAB. And just so the new members know, we have that section after announcements where we're just going to ask you to just introduce yourselves and tell us a little bit about the work you do, and so forth.
So they'll tell us their names now, but then in depth later?
Yeah.
Yes.
Okay.
Decided to do it that way.
We decided.
Hey everyone, Phil Chang. I'm one of your 3 county commissioners, and I'm the one who liaisons to the PHAB.
My name is Heather Laird, and I'm a nurse practitioner. I work at Volunteers in Medicine.
Lori Maines for Lapine Community Health Center. Tammy Polk, Director of Health Services, Benton Schools.
Logan Klassen, Central Oregon Pediatric Associates.
Wendy Jackson, Mosaic Community Health.
Hi, Lindsay Atagi, Pacific Source and PHAB members.
Amy Burrows, Deschutes County Public Health Admin Assistant.
Rich Fawcett, Infectious Disease Physician, Health Officer, Deschutes County.
Yeah, Bacho, Rita Bacho, Public Health Program Manager.
Elizabeth Johnson. I'm the executive director of a nonprofit here locally called the Peaceful Presence Project.
Claudia Sarabia, educator for Planned Parenthood.
I'm Colleen Sinski, executive director of Central Oregon Fuse, small local nonprofit, and the vice chair of that.
And I'm Rob Ross. I'm a family physician by training and represent St. Charles, although I retired mostly from St. Charles back in July. I'm still going to teach at the residency program in Madras. So welcome, everyone. Did anyone happen to have a glance at the May and or August minutes? And can
Maybe the August minutes, but
the August?
well, a lot of the new members weren't here in May,
of
most
course.
likely.
But if someone who read the August minutes, if we could approve or have a motion to approve those in a second, that would be great. Or any discussion.
Make a motion to approve the August meeting minutes.
Second, anybody?
Second?
I second that.
Oh, great, thanks. Any discussion or changes? Otherwise, we'll approve them. All right, thanks a lot.
And we can approve the May minutes too.
Yes. I was gonna go in
Oh, okay.
like in order, but it's okay. So did anyone read the May minutes that were actually there? I did, but
I make a motion to approve the May minutes.
okay, in a second.
I'll second.
Thank you. And any discussion or changes? Otherwise, we'll carry on with announcements and updates from Tom.
Okay, well, actually, public comment first.
Yeah, so sorry, public comment. Is anyone online or in person? Hi.
It's late.
It's okay.
Oh, well.
Listen,
Getting started.
yeah.
I had a bunch of fractures to my back. That's how I ended up.
Sorry.
Oh, survived. That's all.
Okay, so.
So hearing no comments.
Okay, so I'm bringing a public comment item that came to me in the last week. This is from an applicant who had applied for PHAB membership, however, was not selected. And so we had a little dialogue back and forth through email. And I asked him I told him I would be happy to bring this up before the group. And anyways, he was asking if and I have a couple of emails from him. I wasn't able to get an in-depth conversation. If it would be possible for PHAB in the future to begin tracking member racial and ethnic data, because we're not doing that. Our membership that we have, as far as the seats go, is based on expertise and knowledge in certain health professions. And that's kind of how, PHAB has filled its seats. However, he was just wondering if this would be something that with both new members, we ask the racial ethnic data, and then as well as going in the future when we have our membership, that we also track the ethnic data for that. He said he wanted me to bring this up at the meeting, and he said he'd be happy to explore how we can collaborate to enhance public health in the future and discuss this more. So that's basically all the information I have on this, because I wasn't able to have an in-depth conversation. I told him I would bring this forward to the group. So are there any thoughts or comments?
Tom, that's a pretty we do that in other boards in the community. It doesn't seem like an unreasonable request to survey the membership.
Sure.
I would propose something you look at.
Yeah, it's definitely something we can do. I think it's something we can do where we don't have to change the bylaws because we did just change the bylaws for this recruitment, which was a rather lengthy process. But yeah, that's definitely something we could do. Any other thoughts, maybe from any of the longer term members, if anybody has?
We could use the state format to do that as well. And then if they ever wanted us to report, we could do that as well, right?
Okay.
I can't remember. What's the acronym for that? I have too many acronyms. Race, G, what do you?
Soji.
Soji.
Real D and Soji. Yeah.
Real D, that's it. Okay. B.
Okay.
If I just raise one consideration, there is a whole lot of pressure on state and local governments not to do DEI work.
Right.
Threats of losses of federal funding. So, it doesn't sound like this would kind of hit that kind of a threshold, but we should be mindful of not basically putting ourselves in the bullseye where
Good point.
there's federal kind of silly punitive things.
Very good point.
I'll just add that our bylaws and seat structure mirrors the Oregon State Public Health Advisory Board bylaws and structure. So, but having that survey at least is something that we've done with our own board, and it gave really valuable information, not just about demographics, but also like priorities and skill sets that could be brought to the board, and like unearthed other resources like amongst board members.
Yeah. So D-Real is the format used by the state. Okay, great. Well, look for an email from me in the very near future. We'll start there.
Great, thanks, Tom.
Okay.
Any member announcements, updates, important things? Sorry. Oh, I'm sorry. Yes.
I'm Elizabeth Schmidt. I was on the CAC, the Central Oregon Health Council, 9 years. So I know Tom from that.
Yeah.
And I'm really just public today. I was just very interested. And I came on Uber. I thought I got here in time, but I guess I didn't.
Well,
You didn't miss anything.
you didn't miss anything. Thanks for coming. Except lunch.
Yeah.
Help yourself to lunch,
I will.
please.
I'll just listen a bit.
Okay.
We're gonna do flu mist for kids and their caregiver at Fall Fest for COPA. So we rented it, we sponsored the kids zone, so we're gonna have the whole kids zone. And we're gonna try and really be a positive scene around vaccines. So we're just doing flu mist, so there's no like ouchies or pokes, and we're gonna just really try and have lots of fun swag around bouncy houses and like lots of fun. We're trying like a alternative approach to positive vaccine messaging that really doesn't touch on any messaging, but just makes it like fun and out there and positive and very easy and available. So so we're doing it at Fall Fest and we're hoping to do a lot of it. So we'll see.
That's awesome.
And it's flu.
And it's flu. And so like, who knows if that's a controversy or not? I don't really know anymore, but
At least not yet.
It's surreptitiously poke them with
sure.
MR.
Yeah, yeah.
Something.
Yeah.
Well, that's great. Thanks. Any other? I do have one because the residents from the Madras, family medicine residency are now in Madras and actually seeing patients and participating in rotations. And I get to go and I guess try and teach them a little bit about evidence-based medicine. So tomorrow, so that'll be fun.
That's a huge lift. Exciting.
Yeah.
Long time coming project.
Long time coming. We need lots more residencies. Unfortunately, we're not on that path as yet, so we'll keep pushing. November retreat.
Yeah, I just want to bring before the group, every November, instead of having our standard FAB meeting, we have a retreat to do some strategizing. And actually last November, we were very busy doing a lot of housekeeping mostly. We weren't like being strategic about what are certain issues we want to tackle and those sort of things, just because we felt like our membership structure and our bylaws needed some major updating and we just needed to take care of some housekeeping first, which look at our membership now is just about almost 13 people. It's going to be 14 after our Central Oregon Health Council member Michaela Arsenault is going to be, or has applied. We just haven't vetted her application yet. So then we'll have 14 and a pretty full board. So that's the highest the membership has been in ages. So all that work we did last November has really paid off. But wanted to bring it before the group. Should we continue to have a retreat this November to do a little strategizing with what type of advocacy FAB might want to work on, or do we just have take this year off from the retreat and just have a regular meeting? Either way, I'm totally open to. I know the new members might want to retreat, but just thought I'd put it out there just to see what people thought.
I think it'd be lovely to have a retreat, especially with our new members. And I think that we are in a situation where we might have to start looking differently at how we do our work and how we collaborate with each other to move things across the finish line, considering a lot of different constraints. And so I think it'd be really great to continue November together.
Okay, thank you.
I'd be curious to hear, I know the next is the new member orientation, and is there a way to combine those?
Well, what I thought I would do with the new member orientation is have a separate meeting with the new members, either as a group or one-on-one, just depends if we're able to schedule a group one, that might be helpful, but if not, then probably one-on-one, like a short virtual type of meeting. Just kind of give you a public health and issues 101. And last month, Heather Kaiser provided a really good public health overview. And so I probably would use some info from that, but then also have it a little more FAB focused versus just Deschutes County Public Health. So that was kind of my game plan. Then at the retreat, we could potentially have a little orientation aspect of it as well. But this year, not focusing on housekeeping.
Yeah.
Focusing on more advocacy and that sort of thing. Great.
I think it'd be a good idea to have a retreat, speaking of which, just because, we've done some advocacy over the last year, but not as much as historically, just because we were involved with doing the bylaws and charter and all those things.
We did a reasonable amount legislatively.
Yeah.
So
yeah, we supported legislation.
Yeah. And that'd be something you'd learn about in the orientation.
Yeah.
So
if everyone agrees, we will
okay,
carry on.
sounds good. Thank you.
Retreat.
And I'll get working on scheduling the new member orientation.
I could also just say, I mean, this is just a really interesting time in public health. Right? I mean, that's nationally, of the way that public health is, when things like vaccines are being addressed. At the state level, we just saw, I mean, I think that the state legislature and the governor, support public health, but, in a time of very, very limited resources, we didn't get nearly the kinds of investments from the state legislature that I think a lot of us had hoped for in this session that just finished in June. So I mean, just kind of that whole setting is important. We're still trying to figure out, kind of how the PHAB can provide input to the Board of County Commissioners, and have that received and really digested and acted upon. So those are political reasons why it might be a good thing to do some strategizing.
Yeah, sure. And kind of focus a little bit specifically on providing the guidance to the commissioners. Just to talk about how that can be done and that sort of thing.
I want to elevate Lindsay's comment about the importance of collaboration and that this room now represents such a broad swath of organizations that are doing such important work, and that the retreat could be a good time to kind of understand each other's priorities and work better and kind of galvanize that into strategy for public health to the extent that we can. But I guess like with hearing all the political need for the strategy work right now, maybe there's space to have like a group that kind of forms the agenda, because setting that agenda so that we have constructive work time together would be really important. So, and I guess I will volunteer to be part of it.
I was just gonna ask.
I realized that halfway through that sentence. Yeah, be happy to be joined by anyone who wants to help set the agenda.
Yeah, any of the new members, even though it's kind of a new thing, feel free.
Fresh eyes are often the best for this kind of stuff.
For sure.
Yeah, we probably have some precedent here for sure, but I also was curious about just at the state level in terms of the effectiveness, nimbleness, if you will, of the state PHAB. So is it still hold some water? I would think that legislators, politicians would want to at least hear from local PHAB, and it sounds like that's always been the case. So with these two all.
I actually don't. I don't really track the state PHAB.
Yeah, I'm just wondering.
Heather's a member of the state PHAB, right?
Right, but it sounds like it's important and it's helpful. It's usually at least a little bit helpful. If we're silent, it seems like we're almost complicit.
Yeah. Might also be nice to get an update. Hopefully the California, Washington, Oregon Committee on Vaccines and the replacement for our non-functioning federal health system would be good.
Absolutely.
I feel like we should make the agenda closer to November, because I do feel like there's so many things moving quickly that, still changing, that we may want the.
Like do it mid-October-ish.
Yeah, because I feel like
Sure.
if we set the agenda now, we might have 5 new priorities based on 5 new declarations.
Who knows?
Yeah, no, that sounds great. Good.
Could I just make an announcement? I just thought of.
Sure.
Just going back, I just wanted to let everyone know that Oregon Primary Care Association, Mosaic, is hosting the nursing leadership on September. So I just wanted to share that it's really centered around federally qualified health centers. And so I was thinking of Lapine, and if you have nurse leaders who would be interested, we're going to have an OSBN representative, Rhonda Brusack, coming and talking about the nursing changes that are happening. And so that is September 29th, and we'll be hosting it at Mosaic. Please reach out. I'm happy to send you the information. So, and if there's anyone else who's interested. So.
And is that in person and?
Yeah, it's in person. We're really lucky to be hosting it. It normally
okay.
is across the mountains, but we have people traveling to us, so very
Cool.
excited.
Would you mind sharing that perhaps so it could be sent out to the group?
Absolutely.
Yeah, just email it to me. Oh, and before we go to the next section, I was want to remember to let all the new members know that our public health director, Heather, is not feeling well today. And so she is working remotely, did not want to come in and spread any germs. So she wanted to send her warmest welcome to all the new members and convey that she's looking forward to getting to know everyone if she doesn't already and working with you in the future. But wanted to let you know she would be here otherwise. So she normally does come to these meetings.
And a good connection to the state, for sure.
Can I ask a scheduling question for November for the retreat? Is it longer than the hour-and-a-half meeting? Like, should we be reserving right now?
Usually it's like 2 hours.
Okay.
And historically, we've just like extended it like a half hour. It'll be the first Tuesday of the month. I think I've sent everybody the meeting invites, at least for the rest of 2025. And the only reason this is on the second Tuesday is because when we did the second Tuesday after Labor Day last year, nobody came to the meeting. Like 2 people showed up. So we learned our lesson from that. But normally it's always the first Tuesday of the month.
Yeah. We may want to make it a little bit longer than the 2 hours.
Yeah, we
that
could.
we're always
If
rushed, if people are
yeah,
up for that.
What's the date of that?
Remember the second Tuesday? Yeah, that sounds right.
The 4th?
Should be on your calendar.
It's the 4th on my calendar.
Yeah, that's it. Yeah, you should have all the rest of the meetings for 25 on your calendar. Hopefully.
That one might be 2.5 hours.
Yeah.
Okay.
And I can send a hold.
That would be great.
Yeah.
So the 4th, I have it on my calendar as 12 to 1:30, so you're saying it'd probably be 12 to 2:30?
Yeah, either that or we could start at 11:30 to 2 or, you know.
Everyone's checking their calendars.
They fill up quickly.
Yeah, I did send, everybody should have it on their calendar unless my invite went to your junk mail. So.
Okay.
And it's in here, just so everyone knows, it's in this room.
Yeah. So any preferences to starting at half an hour early at 11:30 or just keep it at noon to keep it simple?
Personally, starting at 11:30 would be better, but I could make either way work.
Starting at 11 be even better.
For me, yeah. But it's just clinic, trying to squeeze in a clinic for.
Oh, yeah, those people that have clinical duties for sure. We can
I
work
know
around that.
everyone else is probably different, so I can.
Anybody else have a big preference either way? Okay. So,
As long as it's held on my calendar, either way works for me.
okay. All right, so 11 to 1:30 then, right? Okay. I'll send a invite out. Great.
Okay. I think we can move on then.
Yep.
And we'll start with new member introductions in no particular order, except this is what's on my list. So Wendy, can we start with you? You can just give us a bit of your background and how you ended up here, and what interested you with PHAB and.
I'm Wendy Jackson. I've lived and worked in Central Oregon since 2006. We're connected, Rob and I are connected through Canada. I'm from Alberta, so is he originally. Calgary, Alberta, Edmonton, so we were rivals.
Yes.
Uh,
Hockey teams hate each other. So,
I moved across the country, so I've seen lots of healthcare systems and frameworks from California, Texas, Florida. But moved to Central Oregon in 2006 and worked in the hospitals up until that point. And then made a life change and went into pediatric primary care and spent the 16 years at Central Oregon Pediatric Associates, and started as their nurse manager, and over those 16 years grew with the organization to their chief operating officer. Took a step into healthcare consulting for a couple of years after that, and just loved that space, helping other private practices reach higher levels of patient-centered primary care home recognition, working on value-based payment programs with insurance companies, and then also integrating behavioral health into the primary care in that. And one of my consulting positions took me to Mosaic, and just filled a gap for them temporarily while they had a nursing director absence, and then stayed on there. So I've been there for 2 years, the director of clinical services, which means I'm over their nurses, which is 45 nurses, and their clinical risk and safety program, as well as their employee health, and all of the PCPCH, patient-centered primary care home requirements, and for all of the clinics in Central Oregon. So, and I was really interested in being a member. First of all, I love working in the community. I really enjoyed the community connections that I had across my career, and really love that space of working together. I think we're all stronger when we work together. So really was looking for an opportunity to get back into that space.
thank you, thanks. Marie is.
Remains for the Lupine Community Center. I'm the chief operations officer there. I moved up to Oregon in 2005, moved our family up to Lupine just to have a safer space to raise our kids while they were still young. They'd have a nice safe place to grow. I started working at Lupine Community Health Center in 2005 as a receptionist, kind of worked all of the non-clinical areas of the clinic, and ended up being their chief operations officer. Forget how many years ago now, it's been a while. So I've been there for 20 years. Really love working at a federally qualified health center. Prior to that, I worked at a family practice clinic, some urgent cares, things like that. But working at an FQHC is where my heart is right now, and just love the patient population and just all the different things we get to do for patients being an FQHC.
Your kids are all grown up now.
They are, and I have 6 grandkids now, so.
Whoa.
Enjoying that
Busy.
different type of life now, yeah.
And Claudia?
I'm Claudia Sarabia, I use she, her pronouns, and I am the Education and Training Program Coordinator with Planned Parenthood Columbia Willamette. Yeah, I've really been interested in PHAB because of really the work that I do at my job and also the work that they do for the community. So like I said, I am the educator here in Central Oregon, so all different counties here. And really that is the big component of my job, doing education here in Central Oregon, but also doing outreach. So really being in the community. And both of those really make me strongly believe in the idea that education is power. And I do think that being a part of PHAB is a really great component to bring that idea and framework into being able to share more of first what's priorities with our youth here in Central Oregon, revolving around sexual and reproductive health, and seeing how it can come about with that. Yeah.
Okay. Thanks. Who's next? Heather.
Yes, that's.
Sorry.
My name's Heather Laird and I'm the medical director at Volunteers in Medicine. And I learned about the PHAB through a coworker and I was excited to take part. Sometimes I can feel like I'm on a little island at Volunteers in Medicine. I'm the only provider there and then we have a team of about 8 people right now and they're fantastic, but we get in our own little world. And so I wanted to sort of just broaden my knowledge about public health in Central Oregon. And it kind of goes back to my roots. I went to the School of Public Health at the University of Washington way back in early 2000s and for environmental and occupational health and was really interested in public health at that time. And then I got nervous right as I was getting out of school and I was like, what do I do? And then I went back into nursing school and became a nurse practitioner. And so I'm excited to get back into a little bit of public health, local public health.
And maybe you can tell us a bit about VIM because a lot of people are familiar, like in the old days before expansion of the ACA and all of those things, you guys were incredibly busy, which you'll become again
And
in about 2 years.
Health Heroes.
Yes,
winner
and health
is
heroes, yeah,
Volunteers
that's
in
true
Medicine.
too.
Yeah, so what we do is we serve the gap between right now what we do is we serve the gap between people who there's those who can get on OHP and Medicaid, and then there's if you make just a little bit too much money, you aren't able to get onto OHP. And then especially if you're making just a little bit too much money, you can't afford your own health insurance. It's just astronomically too expensive. And so we screen people to make sure that they fall below 300% of federal poverty level, but above 138%. And our screenings are really rigorous. And we provide free health care. We partner with St. Charles, and so they let us get a lot of free labs, free imaging, also through Cora free imaging. And then there's we have a network of pro bono providers throughout the community that specialists who agree to see our patients for free, which is amazing. And we try to dole out our patients throughout the community so that we're not overwhelming any one provider. And then we have, I'm the only paid provider at Volunteers in Medicine, and everyone else is volunteers who come in and donate their time and see patients. A lot of primary care providers, but we also have a number of specialists as well, so that we keep a lot of the care in-house. Patients drop in and they can see a cardiologist, orthopedist, and then PCPL on the same day and get their vaccines while they're at it, all free of charge. Right now we serve primarily, just happens to be primarily Latino population because of our demographics right now, service industry, construction workers, landscapers, house cleaners, that kind of thing. But that could all change in a few months.
Thank you. And then Elizabeth.
Yes, I'm Elizabeth Johnson. She, her pronouns. I'm the executive director and a co-founder of a local nonprofit called the Peaceful Presence Project. I came to Bend in 2012. Grew up mostly on the West Coast, Montana, Seattle, Oregon area. We founded in 2019, and the work of our nonprofit is really based on something that's known as public health palliative care. So holding this question of how do we create different capacity within communities so that more people know how to support one another in those non-medical spaces when it comes to serious illness, terminal illness, grief and bereavement, end of life experiences in general. So through this, we've done a lot of different work. We have gotten a lot of grant funding to train people across the state of Oregon to what's oftentimes referred to as the end of life doula skill set. So helping people to become more kind of community connectors when it comes to kind of like the community health worker model, you know, to have a different capacity to be with individuals in these really challenging experiences that cause a lot of community-based isolation, disconnect, you know, this feeling of doing it alone. So we've trained about 300 people across the state of Oregon. We have a palliative care training for community health workers. that we partnered with OSU. We do a lot of clinician training. We actually just did a St. Charles-based end-of-life nursing education consortium training for their med floor. There was about 38 people in the room for that. We also have done a lot of advanced care planning. We've partnered with Reach, with Mosaic, with Fuse, with Shepherd's House, and have gone out into the community and completed about 250 advanced directives. A lot of people vulnerably housed or individuals experiencing homelessness. And we've done that work over the last like 2.5, 3 years or so. So really the work of the organization is, I have a master's in urban planning, community development. My other co-director is a palliative and hospice nurse. And so looking at spaces within the community to really initiate these different conversations around how do we care for one another in public health palliative care model. So yeah, we're doing a lot of different things. That's what I'll say about it right now. And so for PHAB, this model is public health palliative care, and I'm really interested to see how do we, I sit on this Public Health Palliative Care International Leadership Council, which focuses on this model around the globe. And I think there's some really interesting models of communities adopting aspects of this to have a more dynamic conversation between health systems, faith communities, local nonprofits, community members to challenge ourselves to be with and for each other in these spaces differently. So excited to kind of catalyze that somewhere within PHAB model.
Thanks. And thanks everyone for applying for membership. It's a great wide encompassing committee now, so wonderful.
And this is one of the biggest recruitments we've done in about 12, 13 years. So.
Yeah, so welcome.
Okay.
And Sarah. Hi, I'm Rob.
Nice to meet you.
Welcome, thanks for coming.
Oh, thank you for having me.
Oh, this is awesome. Are you pretty ready? You're welcome to get food. Well,
Oh gosh, no, thank you. I was just across the street at the Central Oregon Health Council had a QIM meeting at Pacific Source, so it's like in between cold offices and warm offices, and like, it's in the summer, is it fall?
Got breakfast.
Breakfast, oh, it was like lunchtime over there too, they're doing a little bit of a celebration, because yeah, they've had a successful 2024 meeting a lot of QIM, so.
Okay, I think you're all set.
Thank
to
you.
Go here.
Perfect.
Or you want me to advance the slides for you?
Oh, I can do it.
Okay.
Yeah, thank you. Nice to meet y'all. My name is Sarah Van Meter. I'm the immunization program coordinator here at Deschutes County. I've met some of you before. Yeah, hi. Nice to see you, Lindsay. So just a little bit of background on myself. I worked for the county previously on the COVID hotline, in fact, before I came into this role, and before that, well, excuse me, after the COVID hotline, I worked on the immunization team. After things had kind of cooled down, I wasn't necessarily at the fairgrounds. It was when we were still doing the COVID and flu clinics out Sisters, Lapine Way, downtown Larkspur. And so when this position opened up, I thought, oh, it's natural, right? Like if things have tapered down, it's gonna be great. So need I say more? 2 years down the line. So last fall was my first respiratory season. I was like, oh, this is gonna be great. You know, we officially we're out of COVID emergency preparedness, and like we're downshifting. And so I came to like my coalition immunization meetings going, okay guys, here's the plan. We got a plan. We're going to get COVID from state, and we're going to have flu from state, and then, and just kind of going over things. I was like, okay, we're on a steady pace. And then no, here we are. It's been an interesting last couple of weeks, and I'm just gonna kind of like walk you through, this is what a normal timeline looks like. I apologize if you guys, it might be a little difficult to see some of these slides, but I'll do my best. If you have any questions at any point, please be sure to raise your hand. So this is what things look like under a normal respiratory season. As we all know, the respiratory season starts like back in, the January, like when we're still coming off of a respiratory season. Oh, thank you. Generally, that first, the ACIP meets three times a year at least, and this is how things look when everything is normal. And right at the end here, where you see the FDA license approval and vaccines delivered to clinics, that's where we should be at right now. And this is actually what we look like, and a little bit more of a flurry. I get a lot of my information from your local epidemiologist. If you guys are not subscribed, I highly recommend her. I really feel like she breaks things down really easily. Caitlin Jetelina. I'll send you a link, Dr. Foster.
Oh, I think I've been getting.
You probably do. You probably do. So typically, we've had a lot of holdups, and that kind of we'll get more into that towards the end. Then last week we had this announcement that came out on the 3rd. Now I was talking to my supervisor about this morning. We're like, well, it's interesting because the state of Washington is calling it the West Coast Health Alliance. But then in the governor's release, it was called the Western Health Alliance. But regardless, if you didn't already know or hear about this, Oregon and California, Washington, and now Hawaii have all joined together. And we're going to be working to provide clear science-based vaccine guidance. And so we'll see what is going to happen along those lines and where that's going to lead us as far as state supply vaccines for those in the VFC and VAP programs. So we're still kind of in flux with that. So it's been another kind of like, not a bad bump, but another like little diversion that we're all kind of just pivoting with. This is a respiratory illness data channel. This is at the top part is this is from the CDC. This is actually where we're at right now as of the 5th of this month. We're obviously doing really well as far as respiratory illness because it's very low right now, but there is COVID-19 activity that's peaking in many areas of the country. And that's as noted by the increase in ED visits and hospitalizations. Right now, the seasonal influenza activity is low, RSV activity is low. And then just so you know, every state is kind of different as far as like when they announce their RSV season when it hits. For Oregon, we were December of this last year. So kind of late in the game, but it's important to know because that's when we're going to be wanting to look to get our infants and well, people all over the board immunized with RSV vaccine. Right now, the percent positivity in Central Oregon remains low for flu and RSV, less than 1% for the past few weeks, but we did see an uptick in the percent positivity for COVID-19. This data is from our amazing regional epidemiologist, Adrienne Hoyt. Also, I didn't include her link here, but if anybody wants to get on her newsletter, she's now back to doing her weekly respiratory reports. So if you want to keep up on that, find me later and I'll make sure you get hooked up with that. She's happy to share that information. This is the national, again, this is COVID-19 wastewater levels. And we can see that the summer wave is continuing nationally, still at a moderate level, but it's like really the South and the West, Florida and Hawaii that remain hotspots. And then again, with the respiratory illness data channel, is there ED department visits in Oregon. COVID-19 is low, but increasing. For flu, and RSV, very low, no change. And then as far as the wastewater viral activity for COVID is high for Oregon. And that measure is measuring how much virus is actually present in the sewage. And I'm sure y'all remember this from our COVID days as well.
Sarah, do you know it's probably established by CDC, but where do they make the cutoff between low, very low and high? Do you have a sense of that?
Yeah, I should have, they have that on the CDC website and it's kind of hard to get it all in there, but I don't know what the numbers are, Dr.
Maybe
Vincent.
above low for regionally, that's regionally for COVID-19. And the 16% goes through the end of August, so we're a little behind there. And so the 16% is pretty respectable, so I would be on the, careful out there right now.
I think Charles is starting to mask up now and we're,
Sure.
when we're
Wow.
patient facing.
Yeah, the most of August has been, 13 to 16%,
Yeah.
so. Yeah, so it's, nationally it may be not quite as high, but not much.
I'm really sorry.
It's all about COVID.
Yeah, well, I'm not trying to make this all about COVID, by the way, but we will get back to it. But yeah, this is from Adrian's reporting. As you can see, it's hard to tell too by the colors, but we're about right here as far as like in the orange, we're on the rise for week 35. And it is confusing when you look and you say, oh, it's the 24-25 season, but remember, COVID still has no seasonality to it. It gets lumped into the respiratory season just because it kind of used to fall into play that it was better just to give the COVID vaccine at the same time that we were giving the flu vaccine. And so they started having the votes and everything done through the ACIP in accordance with that so that we could make sure that we were one-stop shopping with our patients and getting them both the COVID and the flu boosters as needed. And things, like as soon as the COVID season is announced, like it just continues on, right? So this is national data. And then, like I said earlier, the flu is really starting to stir, but especially in the South. We haven't hit that 3% epidemic threshold that marks the official start of the flu season, but we are seeing that activity is creeping upwards, especially amongst children. I included this graphic and it would probably have made more sense to put it at the end, but I really enjoyed, there's the vaccines and respiratory season ahead, what we know, what we don't know, and how to talk about it. That webinar was put on by the Public Health Communication Collaboration, and I just thought this summed it up really nicely. I do want to point out though, this was kind of a misleading portion right here where they said, oh, everybody can get, like for adults 18 to 50, but they failed to say, highlight that was for the 24-25. Otherwise, I liked this graphic, but let's get right into flu. Not really a lot, but this was like the easiest of the respiratory vaccines that was on our radar because it got voted through earlier on. And so it remains a trivalent vaccine being offered by 4 different pharmaceutical companies. And they decided, because they had not detected the B Yamagata viruses since March 2020, that they were just going to switch from that quadrivalent back to a trivalent. And so this will be our second year going in with a trivalent vaccine. A little bit more of a messy schedule to show you what the products are available for the 25-26 influenza season. Again, the trivalent US vaccines were used 70 through 79, and then again in 2012 through 2013, and they've had an excellent safety record. And for last year, they moved back to being a trivalent. Continues to be no safety concerns regarding that transition. And again, they'll just always be closely monitored. So as I'm sure you guys can imagine, it's not just a science, but also like a little bit of an art form to try to, sorry, I'm trying to get this off. To get it correct as far as like the right potion for our flu vaccine. And of course, they always look down to the Southern Hemisphere because countries like Australia are just getting out of their flu season. So we kind of look to see as much of as far ahead as we can, but we're always going to have to plan ahead and have our flu vaccine ready to go at the time that the companies are ready to make it. So it's like a little bit of a balance. So we just always hope that we get it right. It's never going to align perfectly. And this season's vaccine, or on average, the flu vaccine reduced the risk for needing medical care by 30 to 60%. And then this season's vaccines are all very similar, though we do have that nasal spray flu vaccine that may work better in children, is what they're finding. And there was a study that suggested that the adjuvanted flu vaccine, FluAd, might have worked better in older adults, which is kind of a cool study that they found through the Oxford University Press back in August of last year. Sorry, I'm trying to advance. There we go. So typically we ask people to get their flu vaccine in September through October. I honestly, anymore, I tell people not to get too terribly upset if they can't get into their doctor to get their flu vaccine until late October, early November, because we're finding that our flu seasons are lasting longer into May and June. And we only get that 5 to 6 month efficacy out of our flu vaccines. And so unless you have like an immunocompromising medical story and you are worried about your older population, then we of course want to get them in for their high dose flu vaccine. But amongst those of us that are a little bit generally more healthy, if it's late October by the time you're getting your flu vaccine, you're still totally fine. For most adults, especially those over 65 years and our pregnant persons in their first or second trimester, we want to vaccinate. We should try to avoid vaccinating in July and August unless there's concern that they won't have access to vaccine later on in the season. And then for our children 6 months through 8 years who need 2 doses, they should receive their first dose as soon as the vaccine is available. And vaccinating during July and August can be considered for children of any age who require only 1 dose, particularly if there's concern that, again, later vaccine might not be available. The sample for pregnancy, it can be considered in July and August. If those people are in their 3rd trimester during those months, or people who might be pregnant during the influenza season. Older adults, those are the ACIP recommendations. High dose inactivated influenza vaccine, or the recombinant influenza vaccine, or adjuvanted inactivated influenza vaccine. And then if none of these are available, then any other age appropriate influenza vaccine should definitely be used. I put this up there as just kind of a show. Later on, it'll make more sense when I show you the RSV flow chart for scheduling. It's how I communicated with my front desk this last year to let them know how to really go about scheduling for the flu vaccine. Because as compared to the RSV vaccine, flu is like easy peasy. RSV gets a little bit more complicated. Here at Deschutes County, we just started offering it to our patients last year. So it would have been the 2nd year that RSV vaccine was fully in effect and being offered nationally. So in general, what we're seeing right now is that these are the RSV vaccines that are available for this next season. There's been the GSK's Arexvy and Pfizer's Abrysvo for ages 60 and older in the US. And those two are protein-based, using traditional biotechnology. And there is a small but real risk of the Guillain-Barré, which is about the same as the flu when using the RSV vaccines in our older adults. Also, Moderna, the mRNA vaccine, is expected to become available this season. It did not have the Guillain-Barré syndrome safety signal, but the protection they're finding it does wane more quickly. And any of the eligible adults can get any of these vaccines, and still RSV is only given as a single dose. This is again for RSV vaccine it is covered by the VFC. We're trying to, I don't know honestly how the birthing hospital coverage is looking like for our infants. Last year this was, anyways, it's probably this was for the 24 24-25 season. So I haven't been able to find any data about what they're predicting for the 25-26, whether there's been more hospital coverage for our infants receiving RSV. But
VFC is really hard to sign up for, so most hospitals are not choosing to sign up for VFC just to do the RSV vaccine, knowing that clinics are offering it. So my understanding is St. Charles is not a VFC provider as a hospital, and so my understanding is they are not providing infant RSV vaccine.
Really? Okay.
They do not give it post-delivery.
Okay.
It's a very challenging, like the regulatory requirements of being a VFC provider are very challenging, and to go through all of that just for a new RSV vaccine when they could get it 2 days later in a clinic, at least initially they had decided not to. So unless I have not heard of any changes to that.
Thank you for that.
Yeah. Timing been working out okay in terms of getting the vaccine?
We're gonna get into what she recommends. Yeah, we're gonna get real spicy here. I think it's incredibly challenging, the Oregon recommendation, honest, about waiting until the season starts to prevent an illness.
Sure.
So we're gonna, we'll see what comes up here, but yes, so last year it worked well. I think it's really challenging the recommendation this year is to wait until the season starts before giving it, and I think
It's a really small window.
and they're essentially saying that you can get in all babies under 8 months in a week time period, right? Like the logistics of the recommendations, like as public health folks, our goal is to prevent the infection. And so once the season has started, it's much more challenging for us to prevent the infection. So I find that recommendation wildly challenging, just to be really honest. And I think the thought is that then it lasts longer into the spring, right? But the other side is insurances won't cover it after March. And so it just essentially shortens the amount of time we're allowed to give it, because insurances won't pay for it after the end of the season that they.
And you're stuck with very expensive vaccine that could expire by November before that even the start of the next,
Yeah. And so sorry, I didn't mean to jump ahead on your whole statement, but so St. Charles doesn't offer it across the board that I know about. They do for moms, I want to be super clear, but not for babies because of the VFC barrier.
Right. Yeah. Anytime, any of y'all pipe up, I love it. All right, so basically, again, this is another great infographic from the local epidemiologist, but this is kind of the line out for this season for pregnancy. As last year, Abrysvo is the vaccine that's used, and it's the effectiveness of RSV is passed on to the baby through from the mother for baby's first 6 months of life. And it's been shown to have 82% efficacy in preventing the hospitalization in the first 3 months of life for that baby, and then 69% efficacy after 6 months. And then typically, again, the RSV is a little tricky because then you've got that window of 32 to 36 weeks of pregnancy that you're trying to get them that RSV vaccine. And it can only be during the months of September through January. And this is kind of a repeat of what what we went over in that first infographic. Again, revaccination has not been recommended. And I was just speaking with somebody from East Cascade Women's Clinic, and it has made it tricky because there's women now that are returning to have another child who were previously vaccinated with the RSV vaccine, and they're not recommended to have it again. So we're just it's kind of all, excuse the pun, but in its infancy RSV vaccine. So we don't know how much the mother is going to pass on to that second baby that she's pregnant with after receiving that first RSV vaccine. So there's a lot that still needs to be sussed out with RSV. But they did have with that second season of RSV, thousands of pregnant women did receive it, and it did confirm the safety and high effectiveness of 70 to 85%. RSV vaccine in older adults. We're at the recommendation currently for adults 50 to 74 years of age who are at increased risk of RSV disease can get an RSV vaccine. And there is kind of, a pretty wide range of listing for what recommendations that people would qualify for. And then another, infographic to show you who's eligible. 75 plus, and then adults 50 to 74 with those risk factors. And they're finding that it reduces the risk by 82 to 86% of severe disease. And as far as adults with RSV season, it's not under such strict guidelines as with our infants. And going back, the RSV monoclonal antibody is not a vaccine in the way it does not teach the body to make an immune response. They're a preventive medication because they provide antibodies directly and proactively. The two that are options this year are the Beyfortus, which was last year's as well. I would say with Beyfortus, the tricky part, again, with all the other intricacies of RSV, is that it's weight dependent. So you've got to like take into consideration the weight of the baby and when they're receiving it. The one that's coming up that still needs final write-off from the FDA and the CDC is the influenza or the I was like, I could say it just fine yesterday. The clesrovimab. So I know that Merck is like ready and fired up to get it out there, but I think we're still waiting on that final sign off. Another little infographic there, kind of going over what we already talked about, that for infants that are less than 8 months old and children that are 8 to 19 months with risk factors, if their mother didn't receive it during pregnancy. And it's showing to reduce the risk of hospitalization by 80 to 96%. I'm going to kind of skip ahead so we can touch on COVID before I run out of time. I was just showing you like this is what we had to, it's a bit complicated because that was, we wanted to make sure that our front desk knew how to schedule these, but as you can see, it was quite busy, and I don't anticipate it would get better this year. But as long as we're able to give it safely and effectively, that's all I cared about. All right, so here we go, COVID. I think it's funny that this infographic is gray, because I think we're kind of maybe still in that little gray area. The new 25-26 COVID vaccine targets that LP.8.1 sublineage of the JN.1 virus, which is the current circulating strain. There's still Omicron subvariants, and so that's what our 24-25 formulation was also targeting. So yeah, anyways, we don't know the effectiveness in humans yet, but the updated vaccines have consistently provided 30 to 60% coverage for the COVID boosters that we've had up to this point. And really what we're looking for is, like, again, people may get sick, but they won't get back, or they won't get hospitalized. So that's really the main goal, is to avoid that, that hospitalization and extreme infection. The three on the market this season are the Pfizer's Comirnaty. This is going to be for 5 and older. Moderna Spikevax for those 6 months and older. And then we have Novavax again for the new Nuvaxovid for those that are 12 and older. So if you all remember, back in August 27th was when the FDA approved the COVID vaccines with some restrictions. So it's made it a little bit complicated in the meanwhile, because then for those that are 6 months to 64 years old, they stated that we needed to have patients that had at least one condition that put them at high risk for severe outcomes. And then professional organizations came out with their own recommendations. And so that's kind of muddled the waters as well, in a good way, I would think, in that we didn't have really super clear guidance from the FDA. And so people like the American Academy of Pediatrics came out with their own guidelines that they basically said anyone under the ages of 2 years old should get vaccinated, whether high risk or not. And it gave like pretty much more like permissive language for children that were not in high risk groups, but just whose parents or guardians desired them to have the COVID-19 vaccine. And then also including high-risk children that are living with somebody who is high risk. The American College of Obstetrics and Gynecologists, the ACOG, basically said at any point during a pregnancy or when planning to become pregnant or in the postpartum period or while lactating should receive the COVID-19 vaccine. And then we didn't have any formal recommendations that were given out by the American College of Physicians and Infectious Diseases Society of America. And then because of some disarray, some pharmacies have temporarily stopped giving the vaccine altogether. And at this point in time, all pharmacies in Oregon are requiring a prescription until the ACIP recommendation of the 25-26 vaccines are in place. Also, to add further confusion to all of this is that some states tie the pharmacist vaccination authority to the FDA approval rather than the ACIP recommendations. So in some states, the pharmacists may be continuing COVID vaccination without requirement for a prescription. But what we've found across the board, at least in Central Oregon, is that all the pharmacies are requiring a prescription at this point in time. So primary care clinics could consider even advising some of their patients that are at lower risk of COVID-19 infection to wait until after the 18th and 19th of this month when the ACIP is supposed to meet. And if we get approval, like if ACIP writes off and gives their approval, it's going to open things up a lot more easily for pharmacies who then probably not require a prescription. That everyone's just across the nation, just trying to follow the rules and recommendations as outlined, whether, you know, you are a pharmacist that's still trying to work under your, you know, your rules and regulations as required by your state board, or whether you're a physician that has your own clinic and doesn't know if, like, do I have permission to write this prescription, or are there going to be repercussions if this person doesn't actually have any underlying, you know, health issues. If you're able to get your COVID vaccine, if you were recently infected, like let's say within the last 4 to 6 months, you can hold off. It's really doesn't hurt you to get it earlier, but research has showed that waiting allows some of your antibody factories to update more effectively. And it's a tough call if you were not recently infected. We are in the middle of a wave, but you could increase the amount of protection or the length of your protection if you against the winter wave if you wait a little bit longer. This is talking, and this was her infographic, and I say her being Caitlin Gentilina from the local epidemiologist. This is even just how further confused things are. It's not a fact that no prescription is needed in the state of Oregon, because we've found across the board it is very much so needed, which is why we're getting a high number of phone calls here at the county with people trying to locate COVID-19 vaccine. I'm going to skip ahead. Basically, I've just kind of always been very transparent with what I offer here at the county. And so far, the only respiratory seasonal vaccine that I have in stock is I have very small amount of vulnerable flu population flu in my stock as permitted to have through the state of Oregon. We're waiting further information from the Oregon Immunization Program to see if we're even going to have COVID-19 vaccine available for use as we did last year. And we will have I still have limited amounts of Abrysvo, RSV for adults and pregnant women. And I still always encourage people to try to get it from their provider when they can. But I do still have some Beyfortus that doesn't expire until November if we can hit that perfect window for my infants. List of my resources. One of my favorite quotes about public health. But any questions? I know we're at time, and it's a lot to cover, and I wasn't sure of my audience, and so I didn't know like what y'all are coming with or anything else to add. I love all the information. I love to collaborate. Go for it.
Go for it. Go ahead, Richard. Go ahead.
You know, I think the impression is, as of last week, I think that the pharmacies have pretty good supply, not all of them, of COVID-19 updated booster vaccine. So it didn't get the message that we only got 20 in or whatever. So I would just say that unless we're in a situation where there's a little bit of a local shortage, you know, my personal recommendation would be that we should be recommending the COVID-19 booster, even for those individuals less than 65 who may not have health conditions. Certainly, we've had situations in years past where it's been like flu vaccine shortage. We've had to have, you know, priority groups, and that's really tricky to do. But we're not in that situation with supply right now. So I saw that up there about, you know, it's not a patient with health conditions, you know, immunocompromising diagnoses, et cetera, that maybe wait. I don't think we have to wait personally right now, but you have to have a prescription. Every patient who gets a COVID-19 booster for the season, right now anyway, going to a pharmacy has to have a prescription from the provider. So.
I just want to call it. I feel like that's a really hard thing to put the provider in. I'm just owning. I don't know how you feel, but like, no, not the work. It's like not FDA approved. So what patients are now calling and asking us is to write an off-label vaccine. And RFK called out like it is open season on like you should be suing a provider that like doesn't follow this label. And so like we are now like putting huge amounts of liability, like writing a off-label, not FDA approved prescription.
Yeah.
We like that is, so I feel like we're getting those phone calls and I 100% align, like the public health part of who we are agrees with you 100%, but I feel like we got put in such a hard spot that like we are being asked to write this prescription in a way that like we can't control the FDA label.
So I hear what you're saying, and I think every provider's in that position across the country. We do at least have the Western or West Coast Health Alliance. It's not perfect, but we're talking about, I mean, there will be IDSA and there will be American College of Physicians up there soon, I have no doubt. And even though family practice covered up to age 65, you've got RFK Jr. says over 65 is okay. So you've got recommendations from respectable organizations / FDA / RFK Jr. for all age ranges pretty much. So at least we have that. You know, so you're not totally flying solo, I guess, to some degree. I think one issue is what insurance companies might say. I mean, we don't know. I don't think pharmacies are going to be enthusiastic about administering this if they feel there's a good chance that those patients have to pay out of pocket. So right now with a prescription, they're willing to give it. So just saying, we're trying to amass support as much as
100%. And the other thing I'll add is they stopped returns. So like any private clinic trying to order, I understand VFC is different, but you can't return them anymore. So not only do you have to like not only are you writing like an off-label prescription, but you have to perfectly guess in this really unknown exactly how many off-label prescriptions you're gonna write because you can't return them anymore. So like it's a complete nightmare. So
yeah. To be real clear, it's off-label because FDA is different.
So
I think FDA.
what happens if the ACIP recommends against getting the COVID? Because that's a high possibility against getting the COVID vaccine. Then you're really screwed.
Odds with these alliances of states, which are backed by federal organizations, respectable organizations, and backed by state health departments. So there'll be a rift. I mean, ACIP is not going to be able to convince, I think, ACOG and IDSA, et cetera, and other state health departments to change their position. So there'll be a rift, and we'll have to kind of see where it was off-label prescribing and insurance coverage. And I mean, it's a very unprecedented period of time in public health. I mean, this is the big issues here. Why it's so unprecedented. This is really, really different. And I'm glad we're focusing on some of the, we're not just saying no COVID booster for anybody. I'm talking about, you know, the government, but these are important issues. I mean, we have people without health conditions living with people who, you know, are infirm in some ways. And, you know, I think surging the community without the booster available is going to be a concern. It's already surging now. So anyway, so it's a very unprecedented time, but I think that at the very minimum, depending on what ACIP does, there'll probably be a rift and some disagreements amongst respectable entities.
I'm happy to share Pacific Source as of right now has no desire to change our internal policies with covering for COVID-19. So just wanted to let everyone know that they can still get that reimbursed in clinic and at the pharmacy. And still awaiting any formal recommendations or guidance from the OHA. Really great article in OPB today.
Oh, that's great.
Oh, that's great.
And those things from OHA and from Western Alliance really help, I think, like
Already.
Pacific Source and other insurance providers help them a lot.
And I think without a prescription, reimbursement.
I'm not positive on that. I'm happy to look into it and follow up, but that wasn't articulated in the email.
Okay, all right.
Yeah.
Dr. Fawcett, I'd love to just, I'm gonna go to the easy one, which is flu. I still have providers at Mosaic who are anchoring, we shouldn't actually be giving flu vaccine until mid-October or later, even though we might be getting vaccine and have it available. So the MMRV says clearly start in September and October, and I think that is also because you have such a short window to vaccinate all of these people that the earlier you can start, the better. But they're anchoring to that, oh, well, we want to, have this response and we want to time it perfectly, but we can't get everybody in Central Oregon in a 2-week period.
I think it depends on, predicting when flu season would peak. We don't always know that, and feasibility. So we have to kind of take those factors to make that decision. But I still think September, October is a pretty good recommendation. Those at highest risk, maybe really early is not the best thing. But I feel like for Central Oregon, it's September, October.
Yeah, that's what OHA is. And it's based on one study of like an older adult, right? That 6 months duration. So I always push back that like that was never done in kids. So at least you can like say kids should go earlier.
That response too.
Well, thanks, everyone.
Yeah,
I guess we should call the talk is totally welcome.
And nice job, Sarah.
Thank you.